Cato Institute, long time head policy research director there, who's going to talk today about why it's not the case that the United States has the most free market healthcare system in the world, and what are like the common misconceptions about how this system works and how it can be improved. I hope you will enjoy it. Michael, the floor is yours.
Okay, thank you so much. Greetings, everyone. Thank you for joining us. I am as you said, the Director of Health Policy Services at Cato Institute. I've had that position for 20 years now. The most common question that I have gotten in my 20 years at the Cato Institute and my 28 years doing health policy is which nation has the freest market in healthcare, which nation has the freest health sector and respects the right of patients to make their own health decisions more than any other. And it sort of troubles me to say that after all this time, I still don't know the answer to that. A lot of people assume that it's the United States. There's this common perception that the United States has a free market in healthcare. And as a result, any pathologies that people notice occurring in the United States health sector, people therefore blame on free markets. And just say, well, that's how they operate, because markets are a special sector of the economy where producers and consumers face special challenges that they don't face anywhere else. We often call these market failures, and because market forces don't work exactly the same way, or exactly in the health sector the way economists can draw them on a blackboard in a way that's very simple for the undergraduates to understand. Therefore, if we see problems in the U.S. health sector, that must be the reason for it. Now, before I go on any further, has anyone here ever received medical care in the United States? Does anyone here know anyone who has received medical care in the United States? I can raise my hand for both of those things. No? Yes? Have there been any horror stories, any negative experiences that you've heard about? The people you know that suffered in the United States?
A lot of it actually, not people I know, but I read a lot of stories about the United States healthcare system and how it is so horrible to the point that people cannot get the need that they want from the system itself in situations, for instance, because it's so privatized that when they need immediate care, they cannot get it from the system itself because they have to pay for it. And the insurance is an entirely different problem. But this is I don't know about it, of course, like 100%. This is just a thing that I read on.
These are things that you read and hear in the media all the time. And they lend credence to this, to the conventional wisdom that the United States has a free market in healthcare. You mentioned that people have to pay. In a market system, yes, people have to pay for the medical care that they want. They're getting it from private insurers and private doctors. In a market system, there would be no government provision of health care. You would be getting all of your medical care from private doctors and private hospitals, and so, or private providers broadly. And so, we're finding or identifying features of the U.S. health system and the reports that we're getting about it that corroborate the conventional wisdom. Anyone, any other negative experiences that you read about in the U.S. health sector? There's a lot. I've had some.
None credible.
None what?
I have never heard any credible story about how the American system is not working, because in most cases, if I'm reading something, for example, on the internet, I'm reading some anonymous stories, like I had to pay a lot of money, and I cannot even check it if that's how it works. I only heard that someone is complaining, but people used to complain every time.
Yeah, the internet is, yes. Don't believe everything you read on the internet, however.
As Abraham Lincoln said.
I'm sorry?
As Abraham Lincoln used to say.
Yes. So, however, when you read people complaining about high prices in the U.S. health sector, there's a high probability that their complaints are accurate. Because it's not just them. It is, it's not just random people on the internet. It's prominent media outlets like the New York Times, the Wall Street Journal, the Washington Post, the LA Times, and CNN, and CNBC, and MSNBC, and Fox. They all report on these things. There are health news reporting agencies like Kaiser Health News that report on these things. I've experienced these bills myself, these outrageously high medical bills myself. It's terrible. And even worse than all of that, just a couple of months ago, my father's cousin went into NYU Langone Medical Center for not a routine cardiac procedure. There was going to be a catheterization. They went in through an artery, they punctured her lung, and she died within days of that medical error. That happens a lot in the US health sector. There are horrible things that happen. There are also wonderful things that happen there. The US health sector developed the drug Sovaldi. Has anyone heard of Sovaldi? The US health sector developed most of the world's medical innovations. And those medical innovations include new diagnostic tests, new treatments, and often, well, not often enough, but sometimes, cures. Cures for previously untreatable diseases or diseases where we already had treatments, but they just weren't very good. One of those diseases is hepatitis C. And a number of years ago, about 10 years ago at this point, the Food and Drug, the US government approved a drug called Sovaldi. This is a 95% cure for hepatitis C. It is a miracle drug. It reduces all-cause mortality, so deaths from all causes, among hepatitis C patients by 50%, which is astounding and wonderful. That came from the US health sector. So the US health sector also does wonderful and important things. And people credit free markets with being more innovative. So the fact that it develops, the United States develops more medical innovations than other countries also corroborates the conventional wisdom that the US health sector is a free market. So what I want to do with the rest of our time here is I want to address that myth and walk through some reasons that the United States, some reasons to think that the United States does not have a free market in healthcare. And that there is a different story, a different narrative that better fits all of the facts that we see and all the problems that we see coming out of the US health sector. Problems and the benefits that are coming out. Here's that myth from a prominent, not just a prominent media outlet, but a prominent source of economics information. The Economist, I mean, they must know what they're talking about. They must practice good economics. They call themselves the Economist. Didn't see that one coming. Okay. This is a very persistent myth, or a very persistent claim that you will see about the US health sector. But when you begin to examine the features of the US health sector, you notice something interesting. Not only does the United States have what you might call socialized medicine or government efforts to ensure universal health care for everyone, but in the United States, we have every type of socialized medicine. Not only do we have it, we have every type that anyone has ever invented, and some that no other country has invented. For example, is anyone here familiar with the German health system? No. Well, in the United States, a majority of the US population has health insurance through employers. This says employer only, kind of hard to see. A majority of the population gets its health insurance through employers. That insurance is compulsory. Either you enroll in one of those plans or you have to pay more money to the government. So, right off the bat, a majority of the US population has health insurance through a compulsory health insurance scheme like like Germany has. But we don't stop emulating socialized medicine schemes there. About one-sixth of the US population has health insurance through a system that is like the Canadian socialized medicine system. Denmark also has one that's like this. The way it works is the national government collects a bunch of money in taxes and then sends it out to states, in the case of the United States, or provinces in the case of Canada, or regions, as in the case of Denmark. And those states, provinces, and regions take that money and they administer a universal health insurance program for a defined population where the patients don't pay anything out of pocket. We have that in the United States, just like Canada and Denmark have. In Canada and Denmark, those programs cover the entire population. In the United States, our program only covers low-income people. So it doesn't cover, actually some high-income people who sneak in, and that's a fun story to tell. But we have a Canadian-style health care program in the United States, we call it Medicaid. We also have our own version of the British National Health Service. British National Health Service is an entirely government-run health system where the government not only pays for the medical care, it also owns the hospitals and all of the real estate and physical equipment, or sometimes it leases. And it employs all of the doctors and nurses and all of the other medical personnel. The government owns and finances all of and hires all of the resources and capital and humans involved. And that's exactly how so that's how the National Health Service works. That's also how the U.S. Veterans Health Administration works. About 1% of the population in the United States, those who are veterans of the U.S. military, get their health care through a government-run system just like the one in the NHS. And it exhibits all the good and the bad that the British NHS exhibits. We also have another private health insurance market for people who don't get employer-sponsored insurance. We call it the individual market because individuals purchase health insurance directly from the insurance company on their own behalf. And ever since 2014, that market has operated a lot like the Swiss and the Dutch systems. Private insurers competing to cover individual households, individual consumers or families, in a highly regulated, heavily subsidized health insurance market, where the government controls the prices of health insurance, defines what the health insurance has to cover, and so on, and imposes lots of other regulation. So we got the Swiss and the Dutch system in the United States as well. Whoops, I skipped ahead. Now we're coming to the part where the United States innovates even when it comes to socialized medicine. The U.S. Medicare program covers all elderly people in the United States and some people with disabilities and other illnesses. It covers almost about 1/7 of the population. That's 66 million people. That's about the size of the United Kingdom. And it is more centralized than the British National Health Services. The British National Health Service, even though it has the features that I described just now, it also has a little bit in common with the Canadian and Dutch systems in the U.S. Medicaid program, because the national government sends a bunch of money out to local health governing authorities, and they decide how to spend it. Not so with the Medicare program. The Medicare program, through the Medicare program, the national government in the United States defines what kind of health insurance Medicare enrollees are going to get, sets all the prices for all of the goods and services that those 66 million people are going to receive across an entire continent. The prices that govern 1 billion or more transactions per year. The Medicare program sets those prices. And then the Medicare program writes checks to all the doctors and hospitals that provide all of that care and all those billion or so transactions. The Medicare program is a monument to decentralized economic planning. It is the largest purchaser of medical goods and services in the world, at least in terms of dollars spent, because U.S. healthcare is so expensive, so it's got the advantage there. And it is more centralized than any other nation's health system is. And on top of that, we also have about 3 or 4% of the population that has both Medicare and Medicaid, both the Canadian type system and this Medicare program, because this is for all seniors, and this is only supposed to be for low-income people. So senior citizens who have low incomes, they get both. And then finally, this is a population you've probably heard a lot about. About 8% of the US population is uninsured. 20 million or more people who have no health insurance, okay? Technically, officially they have no health insurance. In a way, they do have health insurance because a lot of them could enroll whenever they want, or Medicaid, or could get insurance on the individual market but choose not to. Okay? But some of them are not eligible for these things, and they are uninsured. And this is another feature of a free market, right? In a free market, insurance is not going to cover everyone. Because if someone already has an expensive medical condition, that is not an insurable event. It's like if you already had a car accident, you can't get insurance to cover that car accident. Because the risk, insurance exists to pool like risk, but there's no risk anymore if you've already had a car accident. That loss has materialized, and you can't insure a loss that's already happened. So in a free market, not everyone is going to have health insurance if they didn't buy insurance before they got sick. So that a lot of people take this to be another indication that the United States health sector is a free market. Because in this country and this country, and this one and this one and this one and this one, everybody has health insurance. But in the United States, not everybody has health insurance. So again, it must be a free market, right? What's actually going on here is the US health sector is anything but a free market. Government compels people to buy health insurance and taxes them. Compels them to spend their own money to buy health insurance over here, and then compels them to pay for health insurance for themselves or others through these government programs, and through the supposedly private market. Oh yeah, down here as well. And the way that the government gets involved in all of these different financing, healthcare financing schemes is, it gets involved in a way that drives up prices in every single one of them. There are incentives in the penalties that the government imposes on you if you don't buy employer-sponsored insurance. There are incentives there that encourage you to buy more insurance than you would otherwise, that drives up health insurance premiums and drives up healthcare prices, making healthcare more expensive and health insurance more expensive for these people right here. Likewise, the Medicare and the Medicaid and the programs in the individual market, what we call Obamacare. You've heard of Obamacare? This is Obamacare right here. These government interventions as well drive up medical prices, drive up health insurance premiums above where they would be in a market system. Again, making it harder for the people who are uninsured to obtain health insurance themselves, say here or someplace else. And so rather than this large population without insurance being evidence of a free market in the US health sector, what's really happening is that population is larger than it would be in a free market in all likelihood, because the government is doing so much over here to drive up the price of health insurance and make it unaffordable for these people. Which, by the way, makes it even more appealing for them not to buy health insurance until they need it. If they're eligible for health insurance here, the higher the price of that health insurance goes, the more economically rational it is for them not to buy health insurance, because in either of these cases, they can wait until they are sick, enroll, and get the medical care that they need. So how much, so this sure looks like an awful lot of government control. But how does it compare to other nations? I mean, how do we know if this is more or less free than the healthcare markets in other nations? Well, the OECD provides some data that sheds light on this question. The OECD measures how much of health spending in each nation is compulsory spending. Compulsory spending meaning, if you don't devote your money to what the government says, the government penalizes you. If you don't give the government your tax dollars to spend on Medicare, Medicaid, and all these other government programs, then the government will ultimately put you in jail. And the same thing is true over here. Employer-sponsored insurance is compulsory because either you enroll in it or you pay higher taxes to the US government, and if you don't pay those higher taxes, then you go to jail. So the OECD looked at, okay, how much should health spending in every nation is compulsory, subject to those sorts of penalties if you don't, and government coercion if you don't spend the money the way the government says, and how much of it is voluntary, where you get to choose where the money goes. And the OECD says that in the United States, about 85% of health spending is compulsory. This orange bar right here is the United States. 85%! That is just 2 percentage points less than Germany, which has the highest share of compulsory spending. It puts the United States in a statistical tie with France, Czechia, Denmark, and Norway. They're all here at about 85%. In the United States, government controls more of the health spending than in the United Kingdom, which has a totally government-run and government-owned single-payer universal health system. The government in the United Kingdom controls less of the spending than in the United States. Same with Slovakia, Austria, Poland, 75%. Another universal health insurance scheme where the government controls less of the money involved, or the money that goes to healthcare than in the United States, and Canada is all the way down there at 72%. Again, a universal population-wide single-payer system, and the government controls less of the spending than in the United States. You might be wondering who this is. This is Mexico over here. This is remarkable because the conventional wisdom is that markets control healthcare in the United States. This shows that that is just not true. If markets were controlling, if markets govern healthcare in the United States, then health spending would reflect the preferences of consumers. They would be able to spend the money they want, and the producers and the insurance companies would only get paid if they gave consumers what they wanted. Compulsory spending doesn't reflect the preferences of consumers, it reflects the preferences of whoever put that compulsion in place, and whoever controls that compulsion over time. And this sheds a lot of light, by the way, on those horror stories that we read about in the newspapers. If the consumers were controlling the money, it would be less likely that those horror stories would persist, because countries around the world show us that you can provide health care more cheaply than we do in the United States. And if consumers control the money, they would want to spend their money on those modes of delivering health care, on lower cost providers, but they don't control the money, so they can't. The government is controlling the money on their behalf, requiring them to enroll in private health insurance and government health plans, or at least fund private health insurance and government health plans that drive prices upward. So, let's talk a little bit now about how government does that and what it does with the control that it has over health care spending. Anyone have any questions yet at this point? I should just keep going. Okay, this chart is fun. This chart's a lot of fun. The US Congress requires lobbyists to register with Congress, tell Congress what they're lobbying on, where they're from, and how much money they're spending lobbying Congress. Transparency measure. I think it's unconstitutional, but they do it, so I'm using the data. I think this chart provides indirect evidence of how much control government has over healthcare and evidence of what government does with that control. You may have heard of the US military, right? It's, you familiar with their work? Maybe? Yeah, they're pretty big. They're kind of a big deal. We got bases all around the world, one of the largest militaries in the world. Congress spends gobs of money on the US military, making a lot of defense contractors very rich. They then take a lot of that money they get from the government and they plow it back into lobbying Congress to encourage them to build even bigger ships and bigger missiles and bigger guns and planes and even sometimes to intervene in some countries, because then you get to use all those cool toys that the defense contractors made, encouraging them to give arms to Ukraine, for example. Defense contractors do this. They spend a fair amount of money doing this. It's about $136 billion million in 2023. I do healthcare. I'm used to saying billion so much. Okay. In 2023, they spent $136 million, but the health sector of the economy spent almost 6 times as much as the defense contractors did to lobby Congress. If we had a free market in healthcare in the United States, why is the healthcare industry spending so much money lobbying Congress? And by the way, they have spent more money lobbying Congress than all these other industries for the last 20 years. If the government has no power over healthcare, why are they lobbying? Are they lobbying for more government power? Well, actually they are. But it's not that there's no government power, there's a lot of it. And so bending that power toward their advantage is a highly profitable venture for health care lobbyists. And so they do it a lot. And what do they do? Or what are they asking for when they're spending all this money lobbying Congress? They're asking for Congress for higher prices. They're asking Congress for bigger subsidies. And sometimes regulatory protection. For example, the pharmaceutical companies themselves spend about 2.7 times as much. Just the pharmaceutical companies spend 2.7 times as much as the entire defense industry does lobbying Congress. Right now, they're fighting President Biden's attempt to reduce drug prices in the Medicare program. The Medicare program pays prices that are twice what other countries pay for drugs. President Biden wants to bring those prices down some, and the drug companies are spending money lobbying Congress to stop him from doing that. Okay? But the main way that they try to lobby for more spending, higher subsidies, and higher prices is by lobbying for more comprehensive coverage for more people. All those expansions of government that I showed before, the tax penalties, if you don't buy employer-sponsored insurance, Medicare, Medicaid, Obamacare, the industry loved all of those because they all tend to channel more money to the healthcare industry, the health insurance industry. And when they do that, when they enroll more people in health insurance, the share of health spending in the United States that comes from the patient and goes directly to the provider gets smaller and smaller. This graph shows what happened with that. Ever since 1961, before Congress created Medicare and Medicaid in 1965, even before that, insurance was getting more comprehensive, covering more people, and the share of spending that consumers were doing themselves was falling. After Medicare and Medicaid, it fell even more, and then Congress expanded those programs and created some more, like Obamacare was around here. And then that share has fallen to about 11%. So on average, consumers in the United States only pay directly for 11% of the medical care they receive. 11 cents out of every dollar is coming from them. The other 89 cents is coming from an insurance company, or their employer, or the government. This has a tremendous impact on their price sensitivity, how much medical care they want to consume, and how much they care about how much it costs. If they're only paying, on average, 11% of the cost themselves, and someone else is paying 89%, consumers are not going to care about what the price of their medical care is. They are not going to shop around to find the cheapest price. Because when they do that, 90% of the savings goes to someone else. So they don't. And they also don't scrutinize what their doctor recommends to them in terms of additional tests and procedures and that sort of thing, like they would if they were spending their own money. Because if they economize, they don't really see the benefit. 90% of the benefit goes to someone else. So, and when insurance companies try to negotiate lower prices with drug companies or with hospitals by threatening them, all right, you didn't lower your price, we're going to exclude you from our formulary, or we're going to exclude you from our network, our provider network. The consumer doesn't want to go along with that because they don't see the savings. The savings goes to the insurance company. All they see is my drug and my doctor are no longer covered by my insurance, and they raise hell with their employer. They raise hell with Congress and the Medicare or Medicaid programs try to do that. That's what's happening with President Biden and Medicare's drug prices right now. The drug companies are getting some traction. And so all of this extra insurance the government is creating has made consumers so price insensitive, and producers have gotten the message. They know that their customers don't care about prices, and so prices for medical goods and medical services have been rising dramatically in the United States over time. These two lines show the increase in real prices. So this is adjusted for inflation. If medical prices in the United States had grown no faster than inflation, both of these lines would be flat against the x-axis. Instead, they have risen, 150, more than 200% over that 60-year period, and they're still that high. We still have wildly high medical prices. That was just correlation, though. There are a lot of other factors contributing to those price increases. But here's evidence of correlation that's a little tighter, a little more direct. In 2010, Congress passed the Affordable Care Act, or what we call Obamacare. That law included a regulation that says that all insurance companies have to cover contraceptives at 100%. So no patient cost sharing. That's equivalent to saying that Congress required everybody who buys private health insurance to buy 100% coverage for contraceptives. So they wouldn't have to pay anything out of pocket. They paid higher premiums, but nothing out of pocket. The orange line is prices for hormones and oral contraceptives. It was falling before that, in real terms. It was falling before that mandate began to take effect. But as it began to take effect, and especially after it took effect, those prices began rising because the producers of those items got the message of hormones and oral contraceptives got the message that their consumers didn't care about, their customers didn't care about prices anymore. So they could jack up their prices. And if the insurance companies tried to exclude their drug from the formulary, they knew that their customers would complain and the insurance company would not be able to get away with it. Because patients generally don't like it when insurance companies make them switch medicines. And women who get comfortable, who've tried multiple birth control options and get comfortable with one, really don't like it when insurance companies try to do that to them, and the producers knew it. So all that extra insurance leads to higher prices, and we end up with a situation where, compared to the OECD average, prices in the United States are 43% higher. These are numbers from the OECD about average healthcare prices across OECD nations. That 143 means that prices in the United States are 43% higher than the OECD average, and it's not because of free markets. It's because of government interventions like the ones I described. Government interventions that have driven the share of out-of-pocket spending in the United States down to 11%, which is a lower share of overall spending, and makes U.S. patients less price sensitive than in patients than is the case in Denmark, the United Kingdom, Canada, and Poland, all of which have universal government-run health systems. Socialized medicine, the United States has insulated consumers from healthcare prices more than nations with explicitly socialized systems. And the same thing happens with quantity. This shows real per capita health spending and how it has changed over time, so it's prices times quantity. Consumers are less discerning about the things your doctors recommend. They can consume a greater volume of services, and you can see that prices, or total spending, has risen dramatically in real terms from about $2,000 per person to about $12,000 per person over that 60-year period. And given us a situation where right now, the volume of services that consumers in the United States receive is 49% higher than the OECD average of 100. Which is, who's at 100 right now? United Kingdom. For all the rationing that goes on there, they're average among OECD nations. We're left with a result where, with the following result. You may have heard in the media that healthcare consumes a larger share of GDP in the United States than any place else. 16.6% of GDP. And it's true, that's a lot. Number two is what? Germany right here. That's not even 13% of GDP. But here's what's really interesting. If you look at compulsory versus voluntary spending, what you see is that compulsory spending, you may not be able to see it, but this is orange and this is blue. So I'm glad I put that line there for you. Compulsory spending consumes a larger share of health spending consumes a larger share of GDP in the United States than total health spending, voluntary plus compulsory, in any other OECD nation. This 14% is actually twice the share of GDP of total that health spending consumes in bulk, about 7%. So when people asked, why does healthcare consume such a large share of GDP in the United States? The answer is not free markets. The answer is because government compels people to spend, in the United States, to spend that much money on healthcare. It's the opposite of a free market. All right. There are other indications that the U.S. health sector is less free than other countries, and people in the United States have less freedom when it comes to their medical decisions, to make their medical decisions, than residents of other countries. This was a study from 2009 by the U.S. government, and I don't know if you can see that at all. It looked at 86 different drugs across 5 countries and counted up or tallied the regulatory barriers the government puts in the way of people accessing those medicines. And in the United States, the regulatory barriers, blue is good here and orange is bad. Blue is you're free to make the decision yourself about whether to use those medications. Orange is you have to get permission from some government-appointed gatekeeper, usually a physician. We're talking about government-required prescriptions here. Okay. And in the United States, you needed to get the government's permission for a lot of those. Your freedom you were free to put, it's only about half of those yourself. Just about the same as Italy and the Netherlands. But in Australia and the United Kingdom, those burdens were either less overall or less burdensome because because in Australia you could buy more of those drugs by yourself without getting anyone's permission. And if you had to get someone's permission for this 13%, it was a pharmacist. And that's way easier than getting a physician's permission. In the United Kingdom, you can only purchase a third of them by yourself, but another 39%, you only need a pharmacist's permission, which is, again, it's easier than getting a physician's permission. So at least Australia, and maybe residents of Australia and the United Kingdom, have more freedom to self-medicate than the United States. This one sticks in my craw, coming back to contraceptives. The United States requires women to get a prescription in order to purchase oral contraceptives. This is a safe drug. It has some risks, but it's been on the market for 60 years, and it's gotten safer, and women know how to navigate those risks. And the government still requires them to get a permission slip from a government-appointed gatekeeper before they can buy it. That not only increases the cost of getting it because you need to spend time and money to see a physician, but it also increases the prices for complex reasons I could describe. So it takes away the right to make this decision themselves and increases the prices of those medications. But you'll notice that Canada, Western Europe, some South African countries, Japan and Australia also impose those requirements. So you might say, well, this is a sign of an enlightened society, right? Maybe not. Saudi Arabia also imposes prescription requirements on contraceptives. But more importantly, you've got over 100 countries around the world where women have more freedom to purchase contraceptives than they do in the United States, where you don't have to get permission from a government-appointed gatekeeper. Okay, now, while I painted a picture of a very government-dominated health system, I want to, let me make sure I have where I think, yeah. There are corners of the U.S. health sector where people do have enough freedom to innovate, and they produce it, and when they have enough freedom to innovate, where market forces have enough room to breathe a little bit, they produce some really cool stuff, some really good innovations, such as, I'm going to talk about one that happened here in the employer market, some that happened in the individual market before and after Obamacare happened, not really in the individual market, but similar. And some that happened across both, where there was just enough room for innovators and market forces to experiment and to breathe. In California, some appliers realized, you know what, because of this moral hazard, we can't get the prices down for things like lab tests, colonoscopies, hip and knee replacement, cataract removal, arthroscopy of the knee and shoulder, high-tech scans like CTs and MRIs. Try as they might, they could. Some hospitals were charging only $12,000 for hip and knee replacements, but others were charging $60,000, 5 times as much, and they couldn't get the prices down at those hospitals. If they tried to, by excluding those hospitals unless they lowered the prices, then the patients would complain because the patients don't see the savings in their premiums, the employers do, and the insurance companies would lose business. So they're like, well, what do we do? Well, they came up with an insurance design that took advantage of how consumers behave in a market system when they are price sensitive. They said to the people who got hip and knee replacements, we will pay $30,000. And you can go to whatever hospital you want for your hip replacement or your knee replacement. But if it costs more than $30,000, you're paying for the balance. So they were 100% price sensitive in the margin. And so what did they do, the patients? Well, a lot of things happen that supposedly don't happen in healthcare markets, because healthcare markets are a special sector of the economy where market forces don't work. And yet, the following happened. Consumers began demanding price information. Because they were the ones controlling the money, they cared about money involved, they were demanding price information because they were the ones controlling the money. They got price information from the hospitals. This is amazing enough in itself, because hospitals in the United States are notorious for hiding their prices and not giving you clear and transparent prices. But then, even more amazing, the consumers changed their behavior. About 1 out of every 6 patients who got a hip or knee replacement switched from the high-price hospitals to the low-price hospitals. Okay? And it gets even better than that. The hospitals responded by lowering their prices. They were getting killed on market share, on patient volume. And so they said, we got to stop this. They went to the insurance companies and said, let's reopen our contracts because we're going to lower our prices. And even though the average price reduction for over a 2-year period for hip and knee replacements was about 20%, at the high-price hospitals, it was 37%. A $16,000 savings per procedure just by making the consumer price sensitive at the margin. And here's the beauty, and this happened not just for hip and knee replacements, but for all of these services. Just by making the consumers price sensitive. The consumers got the prices down below the lowest price that the insurance companies could get. And it all happened without anyone going out without any of these services at all. Everybody got all the services they want. There was no rationing involved. What happened was price competition that drove prices down. And if you want universal health care, this charge should be your obsession. Because falling prices is how we make everything in this world more universal. Falling prices is how we've made food so universal that we are keeping 8 billion people alive on the planet right now. Something that humans have never achieved before. It didn't happen because of a universal food program. It happened because of innovations in food production and food distribution that drove down food prices so that we could get it to more people before it's spoiled and keep them alive. We need the same sort of a revolution in healthcare that drives prices down, and so you would think that in the United States people would be celebrating this, and health economists like me would be talking about nothing except this wonderful innovation. But no one's talking about this innovation in the United States, except for me and maybe 1 or 2 other people, because most health economists in the United States don't want this kind of universality. They just want the government to promise that it will make healthcare more universal, instead of actually making it more universal. And because this hasn't caught on in the United States. Why hasn't it caught on? Because the government penalizes these sorts of innovations through the tax code. Not intentionally, but there's a very real penalty on every dollar of savings that an insurance company or consumers produce with these sorts of strategies. A penalty of about 33%. I can discuss that penalty if you're interested. Okay, next innovation. And I should say, I just want to emphasize, if consumers control the money, markets all, not just 15% above, 100% of the money in the health sector. These are the outcomes that markets would just produce as a matter of course, because that's what consumers want, and they're the ones controlling the money. Another innovation that markets produce as a matter of course is different ways of organizing and paying for medical care than the ones that dominate in most advanced nations. I mentioned the British National Health Service and the US Veterans Health Administration. They are integrated healthcare delivery systems where the same organization that's paying for the medical care also owns the hospitals, employs the doctors, and so forth. The Veterans Health Administration, the British National Health Service, are not, those government-run integrated health systems are not the only integrated health systems. There is a private one in the United States, we call it Kaiser Permanente. It's actually older than either the British National Health Service or the Veterans Health Administration in terms of being an integrated health system. This is something that markets produce all on their own. And these types of health systems face unique incentives to invest in things like electronic health records. Kaiser Permanente has been using electronic health records since the 1960s. Congress didn't get around to mandating them until about 2008, or requiring people that subsidize this through Medicare to use them, doctors to use them, until about 2008. The market beat the government by about 50 years. And Kaiser has been using those electronic health records to let people check their lab results online, to email their doctors, and generally to make healthcare more convenient. Because Kaiser is an integrated health system, it also makes healthcare more convenient by making it easier for doctors to confer with each other about a shared patient and provide clear information and instructions to that patient. In the United States, that is not the norm. If you have multiple doctors, you have to go see each of them yourself. They never talk to each other. You might get them to send your each send their medical records to the other, but they never confer with you and provide you one set of instructions. They're always providing you different instructions. They're often conflicting. It's a total pain in the butt. But my sister-in-law, my brother's wife, when she had to have a brain tumor removed from near her left ear, she and my brother were enrolled in Kaiser Permanente. And she raves about the quality and the convenience of the care that she received, because all of the specialists that she needed to see were in one building. So was the pharmacy. So when she needed a prescription filled, she just walked down one flight of stairs. And if she had questions, she could drop in over here or over there, and it made medical care more convenient in other ways as well. But perhaps most dramatic is when you have this sort of an integrated system with a defined group of patients, and you have electronic medical records, you can start measuring what's happening with your patients. You can measure inputs and outputs and find out what's working and what is not. These sorts of health plans are an engine of medical research, the sort of research that improves the quality of care. That's not what happens in most of the U.S. health sector. Most of the U.S. health sector does not have the means or the opportunity to do that sort of research, but Kaiser does, and it produces wondrous results when it does. Is anyone here old enough to remember the drug Vioxx? No, I'm the only one. About 20 years ago, a company named Merck introduced this new drug onto the market, Vioxx. It was a painkiller. It was supposed to be a miracle drug, work wonders. But it turned out that it caused heart attacks and killed people. The FDA let it onto the market. The U.S. Food and Drug Administration, the U.S. government, approved it for sale. Conducted a few tests, didn't detect any heart attack, reliable evidence of heart attacks, and so they let it out onto the market. But Kaiser Permanente pulled its records on millions of patients and said, wait a second, because the FDA's trials only had a few thousand. They pulled records on millions of patients, and they said, well, this is causing heart attacks, we're pulling it off our formulary, and that is how the FDA got the information it used to then ask Merck to remove Vioxx from the market. Kaiser Permanente, a market innovation, beat the regulators at their own game. This is something that happens in a market system for healthcare as a matter of course. Without the government trying to plan anything, it just happens. You would think that this is something that people would be raving about and trying to build upon and trying to emulate and say, thank God for market innovation. But instead, what happens is, for 100 years, the government has been using regulation to block plans like Kaiser Permanente. So, originally explicit at the behest of physicians who didn't want the competition from Kaiser-type plans. But they're not doing it to frustrate Kaiser right now, but those regulations are still in place that create barriers to entry for Kaiser-type plans. And the US government's tax code penalizes Kaiser-type plans. And the government heavily subsidizes competing ways of organizing and delivering medicine. So instead of letting this sort of innovation occur and flourish, the government is crushing it in almost every way you can imagine. And there are other people today who are trying to create new Kaiser plans, and those regulations and other regulations are standing in the way and stopping these sorts of quality improvements that a market would deliver. Okay. I talked a little bit about Obamacare. It's that Swiss-Dutch type health system that we had over here that covers about 10, 20 million people. The insurance is not all that affordable. It's really expensive. When they passed Obamacare, premiums for a lot of health insurance premiums for a lot of people doubled and tripled because of all the regulations involved. But there are markets in the United States that are exempt from Obamacare's regulations. And in those markets, insurers are able to provide comprehensive coverage to most people for premiums that are 60% less than the lowest cost Obamacare plans. That's what these blue dots here is. For a 64-year-old female in all of these cities across the United States, these blue dots show the lowest Obamacare premium available to her, to that 64-year-old female, okay? The orange bars show the range of premiums available to her in that Obamacare exempt market. And in every case, she can get coverage where the premiums are much, much lower. Markets enable that to happen. You can also buy more coverage than Obamacare requires you to buy. In a free market, that's what freedom means. You can purchase more than the government is requiring if you want. If people aren't demanding that, what does that tell you? It tells you they don't want that. And these sorts of plans aren't just comprehensive. They make access to care more secure, as I'll explain in a moment, than Obamacare does or than employer-sponsored insurance does. And so you'd think we would be celebrating this market success, but no, instead, what President Biden just did a few weeks ago that will take effect in September is he crushed this market so that almost no one is going to want to buy health insurance in this market. He limited the duration of these plans, these Obamacare exempt plans, to 3 months. Because he didn't want Obamacare to have the competition. Nonpartisan experts were saying this is comprehensive coverage, much lower premiums. Markets are making healthcare more universal. He said no. Also making access to care more secure. Another health insurance market where Obamacare's regulations did not apply is the individual market before Obamacare. This graph uses data from that individual market before Obamacare to show that your probability of losing your health insurance and ending up uninsured if you had one of those sorts of plans was less than if you were employed, equal to or less than if you had health insurance through an employer. If you were a 28-year-old male in poor health or a 28-year-old female in poor health, so we're talking about the sick here. If you were sick, enrolled in one of those pre-Obamacare individual market plans, you were less likely to end up uninsured than if you bought the kind of insurance the government was compelling you to buy, insurance through an employer. And that market was even innovating in ways to make these plans more secure and to fill in the gaps with employer-sponsored insurance, to help these people who lost their employer-sponsored insurance, usually when they changed jobs, if they changed jobs after they got sick. You would think, oh my gosh, the market is doing as well or better than the government's horse in this race. We should be celebrating this, we should be encouraging it, It's even filling in the gaps in the type of insurances. You know, the government compels people to buy. When you hear about pre-existing conditions in the United States, it's usually because someone had employer-sponsored insurance, got sick, and then got so sick they couldn't work anymore and lost their employer-sponsored insurance. So that's not a feature of the individual market for insurance. This coverage can last your entire life, and did until the government intervened. And market innovation was trying to fix that problem the government solved, of people losing their coverage, or fix that problem the government caused of people losing their coverage after they got sick. But instead of celebrate and encourage this sort of innovation, the government, with the Affordable Care Act or Obamacare, outlawed that innovation. Okay. Some room for hope from the United States. A lot of the regulations that I've been talking about are regulations on health professionals. Those are the regulations that have blocked Kaiser Permanente type plans, for example. And they generally, and as a result, they make healthcare more expensive and also reduce the quality of care. One way that they make healthcare more expensive is they reduce competition for doctors in Maine by every state in the union does this. They say if you want to practice in our state, you've got to get a license from our government. It doesn't matter if you have a license from all the other 49 states. If you don't have a license from Maine, you can't treat patients in Maine, either in person or over the internet from someplace else. It's very expensive to get a license, so most doctors don't, and that takes away your right as a patient in Maine to see a doctor from another state who comes to you or have them treat you via telehealth. Those licensing laws are barriers to entry into those markets. They're barriers to trade. They're also barriers to innovation because they impose a particular burden on Kaiser-type plans. But thankfully, some states are tearing down those barriers. These dark shaded states have begun to recognize the occupational licenses that other states issue. So if you're a doctor in any of the other states, you can come into Arizona and practice in Arizona. Or you can see patients in Arizona over the internet using Zoom, telehealth, whatever you want to call it. Not all of these states, these are just occupational licensing reforms where they will recognize some occupational licenses from other states. So not all of these states apply that reform to healthcare. I live in Virginia. They have not included health professionals in their occupational licensing reform. So I still can't see doctors from all the other states. This is a step in the right direction. It's a liberalization on which we can build to try to tear down these barriers and introduce market forces into healthcare in the United States. Likewise, there are still a couple of markets where you can buy comprehensive long-term health insurance that is exempt from Obamacare's worst regulations. They are U.S. territories. There are 5 of them. Guam, American Samoa, the Northern Mariana Islands, Puerto Rico, you may have heard of that one, and you may also have heard of the U.S. Virgin Islands. Health insurance in these territories is exempt from the worst federal regulations. And so, legislators in the state of Florida have introduced legislation that says to their employers and their residents that they will recognize, the state of Florida will recognize health insurance from the U.S. territories. That insurance companies who get a license to sell health insurance from the U.S. territories can sell to employers and individual consumers in Florida. If they do that, then they will be able to make available to them this type of more secure, more affordable health insurance. Once again, that provides comprehensive coverage that costs 60% less than Obamacare plans. So that's another reason for optimism and hope, because there is a market for health insurance in the United States on which we can build. And finally, one more policy innovation on which we can build. I mentioned that employer-sponsored health insurance is compulsory in the United States. It's compulsory because the government says either you let your employer control a huge chunk of your compensation and use it to purchase your health insurance. And then you enroll in that health insurance, and it's lousy health insurance because it disappears when you change jobs. Or you can take that money as cash, wages, but you have to pay taxes on it. About 33%. You'll lose about 33% of that to taxes. This is real money, okay? Because the average amount that the average worker with family coverage through an employer pays for that coverage is $24,000. The U.S. health sector is expensive. This is real money that we're talking about. So if they want to take that money as cash and go buy their own health plan, they lose $8,000 to taxes. That is an implicit penalty, but a very real penalty on controlling your own money. And this explains that first slide I showed, where about 50% of the U.S. population has health insurance through an employer. They want to avoid that $8,000 penalty. As a result, the employer gets to control so much of their work, of their earnings, and across the entire economy, employers get to control about $1 trillion or more of their workers' earnings. This is how much employers spend on employer-sponsored health insurance over time. It's now more than $1 trillion per year, and that is all the workers' money. It all comes from their compensation. It doesn't come from profits. It doesn't come from any place, higher prices on the goods and services that employers who offer health insurance to their workers collect. No. It comes out of workers' wages. The workers' cash wages are lower because employers take money out of that and put it into spending on health insurance. So this is how much money, of their own money, workers lose control over. But you see this little orange strip down here? That is a policy innovation in the United States that we call health savings accounts. They are tax-free accounts where workers can put some of this money and then they can control it themselves. There are lots of limits on health savings accounts, so right now, workers can only control about 4% of that $1 trillion every year. But it's a base on which we can build by expanding health savings accounts to give workers control over all $1 trillion of that money, their own money. And that's important because if you do that, you'll make them price conscious in a way that they've never been. You'll see prices falling in a way in the United States in a way that they never have. And you'll make healthcare more universal. You'll see how free markets work in healthcare, and you'll see that they work to make healthcare more universal than other systems do. And that's all I got. And I'm happy to take any questions you have about anything that I said here or any other aspect of health, economics, and policy, or the Cato Institute, or what have you. So thank you.
Yes, actually I have some questions. First of all, in Poland, the pharmacist issued receipt for drugs is not very popular, and in practice it is as burdensome as in the case of doctor issued permission for buying some kind of drugs. How does it work in Australia and United Kingdom that it is less burdensome for the patient, like this shall issue permission to buy drug that only in some conditions are met, it is issued only if the patient wants it, or how does it work, because it is not present in our system. So if I see that some kind of pharmacist is going to issue me a permission to buy drug, it's at least for me, no difference than some kind of other state professional or state officer to issue me a permission to buy drug.
Okay, so
explain that.
Sure. We at the Cato Institute, my colleague Dr. Jeffrey Singer and I wrote a whole paper about this, and so there's a lot of information about the history of government-imposed prescription requirements and how government uses that power, what happens when it has that power. And interestingly, when all of the available economic data show that when you give government the power to impose prescription requirements, you would think that that would make patients safer because then they would have to go get advice from a doctor before they use dangerous medicines, but it doesn't. There's no evidence that makes them any safer. In part, economists have hypothesized because patients are naturally very careful about the drugs they consume, but when they go to the doctor, they aren't as careful because they figure they have someone else who knows more, providing advice, and often that advice is good advice, but often what the doctors do is they prescribe riskier drugs than the patient would have taken themselves, and those riskier drugs that the patients then take end up causing harms that offset any benefit. So, with that as background, another thing we noticed when we were studying this is that governments are very slow to move, they don't innovate very much, and so in the United States, when the Food and Drug Administration really just claimed the power to require prescriptions, Congress just didn't give it to them. They said that they have to get a prescription from a licensed health professional, and the people who decide who are the licensed health professionals who can provide prescriptions are the states. The states, this is part of their clinician licensing schemes. The states decide who in this state gets to write prescriptions and for what drugs, okay? So the FDA the national government just said prescriptions, and then the states got to decide who gives the prescriptions, and who do you think has the biggest say in those questions in each of these states? Well, obviously doctors are traditionally people who wrote prescriptions, and they went to the states and lobbied to prevent the states from allowing anyone else to write prescriptions. Because that's business they would lose to other healthcare, to competitors, rather than having people come and see them. So in the United States, what happened was only doctors could write prescriptions. That has changed some over time. Some states now allow nurse practitioners to prescribe some drugs. But in Australia and in the UK, this is one reason why you want diversity and decentralization in lots of governments rather than just one. They went a different way. They allowed pharmacists. Their national government created a category of prescription requirements where you don't need to see a physician. You can go to a pharmacist. They call it's not over the counter where you can just buy it yourself, but behind the counter, so the pharmacist has to give you the drug. And if you think about it, that makes a lot of sense. That could be a way to get consumers the information and advice they need without requiring them to go across, to make schedule an appointment with the doctor, take time off of work, go across town for the doctor's appointment, and pay for an expensive doctor's appointment. If you're going to go to the pharmacy anyway, it's not burdensome, it's not that much more burdensome, just have to ask the pharmacist, hey, can I have this drug or that? And have them say, oh yeah, I have to ask you this question, are you diabetic? No? All right, then you can have this drug. Much less burdensome than having to go through all those steps to see a doctor. And much more innovative. And there were prescription requirements that manufacturers imposed on their own products before the government had the power to impose these prescription requirements. And if we had just left it to manufacturers, they would have been innovating in this direction also. Not just pharmacist permission, but you can envision them coming up with things like kiosks. I don't know if that's a word you learn in your English class, but one of these machines that gives you, where they've got a screen, maybe you can sit down, it can take your blood pressure, it can ask you some medical questions about whether this drug is right for you, even make you take an exam, answer to make sure you understood the instructions, sign, take a picture so they know who's buying this drug, and then only then dispensing the drug. There are lots of ways that the market could innovate to provide consumers the information that they need, but they can't do that when the government is imposing prescription requirements on in a one-size-fits-all way that precludes those innovations. Does that answer your question?
Yes, thank you. Okay. The second question is about this example with 50,000 threshold for some kind of medical procedure.
Yes.
Has this example been analyzed with the occurrence of the medical errors? Because some, for example, some people who are against the market distributed health system can argue that if the prices of the service is lower, the occurrence of the medical errors can rise up, because those somehow it is connected. I do not support such view, but could you answer this?
So if they're not, maybe if the doctor's not getting paid as much, they're not going to be as careful, they're going to cut corners.
For example, yes.
Okay. I can see that. I mean, it's not a totally unreasonable argument. I've never heard it, I don't think, but it's not totally unreasonable. And medical errors are a real problem. What happened to my father's cousin was definitely a medical error. And the estimates in the United States are, they range, the estimates of annual deaths from preventable medical errors range from 50,000 per year to 400,000 per year. The truth, there's a lot of disagreement about how to estimate medical errors, but no matter where the truth is, if it's in between those two numbers, it is a horrendous human toll. So medical errors in the United States are a very real problem. I've never heard anyone ascribe them to payment rates being too low, but I can tell you what people ascribe them, have ascribed them to, and it's on this chart. All three of these major government interventions, and this one as well, encourage a certain way of paying for healthcare, a certain way of paying doctors, a certain way of paying hospitals. We call it fee-for-service. What does this mean? Well, it means that when the doctor provides a service, they collect a fee. And if they provide more services, they collect more fees. So there's an obvious incentive here to keep providing more and more services, because that's how you make more money. That is what the tax penalties on efficient health plans, the tax penalties on people who don't enroll in employer-sponsored insurance encourage fee-for-service payment, because it effectively penalizes you for every dollar you don't spend on health care. And if you enroll in a more efficient type of health plan that spends less on health care, then you pay a penalty on the savings. You lose some of the savings. So the savings aren't as great from those more efficient health plans, so more people enroll in the inefficient health plans, the fee-for-service health plans. So this encourages fee-for-service. The Medicaid program still pays to doctors and hospitals on a fee-for-service basis. The Medicare program, again, the largest purchaser of medical goods and services in the world, pays doctors on a fee-for-service basis. So do most insurance companies in the individual market. Okay? So doctors and hospitals are getting paid on this fee-for-service basis. What does that have to do with medical errors? Well, under a fee-for-service payment system, if you provide a service for someone and it injures them, you make a mistake and it harms them, you get paid. And then, because you harm them and you have to make them whole, you have to provide them another service. And you get paid again. And so fee-for-service payment has this built-in incentive that encourages medical errors. Does it mean that doctors are like, hey, if I hurt this patient, I'll make more money? No, of course not. But avoiding medical errors requires investments. It requires studying, okay, how did this error happen? How did we not clean this emergency room or this operating room enough? How was it that we passed on an infection when we inserted a central line? What are the steps that we could take to make sure this doesn't happen again? Maybe it was a medication error. Oh, we need to invest in electronic health records so that we can scan the barcodes and make sure that the right patient is getting the right medicine at the right time, in the right dose. All those things require investments. And in a fee-for-service world, If you invest in avoiding that error, then you lose, then you are out the money that it costs to create those systems that avoid the errors. So you lose that money, you have to spend that money, and you also lose the money that you got from fixing your errors. So that's how fee-for-service encourages more or allows or tolerates more medical errors. It's because if you try to eliminate them, you lose money. And there's evidence of this happening in the US health sector. Also, any quality improvement that results in fewer services, fee-for-service discourages, because if you improve quality, you lose money. And there are lots of examples of providers improving quality and then losing money because Medicare paid less as a result. And because employer plans pay them less as a result. That is not how it works here. In Kaiser Permanente, the insurance company and the healthcare providers are all part of the same corporate umbrella. They don't get a different fee for every service. All the money they collect in premiums from all of their members is in one big pile of money that they then have to provide healthcare to all of their members. They don't get paid more for doing more. The more that they do, the less money they have left over. So they profit by doing less. Now, they might ration care to people. It's been known to happen. But you know what else it encourages them to do? To invest in electronic health records to avoid medical errors. To invest in electronic health records. So under fee-for-service, if you're a radiologist, and you give people films, you know, the films that you hold up to the light, instead of backing it up on a computer, you just give it to them as films and then they lose it. You get paid again because you have to do that scan, that x-ray, or that MRI again. So there's an incentive in fee-for-service for that kind of waste. And then another disincentive to invest in electronic records that avoid that waste. Because you're out the initial investment in electronic health records, and you lose the revenue that you got on the duplicative tests. But Kaiser, if they give you a film and you lose it, then they have to pay for the second MRI or CT scan or X-ray. So they invested in electronic health records so that because it would save them money, and then they use that to avoid medical errors. But again, you think we'd be celebrating this, but the government imposes regulatory barriers, they impose special barriers to Kaiser-type plans, penalize their efficiency through the tax code, and subsidize their competitors through Medicare and Medicaid. So that's what's driving the problem of medical errors in the United States. Again, it's not free markets. Free markets reduce medical errors. What's driving the problem of medical errors in the United States is the fact that the government rewards them. And I had a point that I wanted to make about medical malpractice, but I forget what it was. Yeah?
Is the United States at any point in history, modern history, experience something close to the free market or something akin to that when it comes to the healthcare system?
Did you say modern history?
Yeah, because
When does modern history start?
to me, 19th century and after.
19th century and after, well then yes. So I would say that there was a free market in healthcare in the United States until about 100 or 110 years ago. So around 1910. Around then is when a number of things started to happen. First, states began imposing clinician licensing laws. States began saying, you have to get permission from the government if you want to practice medicine. We will decide whom you as a patient can choose as your healthcare provider. Okay, so the government is taking away people's right to make that decision for themselves and barring entry into the market for healthcare. That's when things started going downhill. That's when we no longer had a free market. And states enacted those laws at different times. I think some were in the 19th century, but they really began to pick up steam at the turn of the century, and around 1910 is when I think all of them had enacted those laws. Then came 1913, a very dark year in US history, because that is when Congress imposed the second federal income tax. The income tax is what led to, oh wait, is this the right one? Yeah, I have just that one, right over here. The income tax is what led to this. It's what led to our employment-based system. When Congress passed the income tax in 1913, there was no such thing as health insurance as we know it. And so Congress didn't even mention employer-sponsored health insurance in the legislation creating the income tax. But when employers started raising the question, hey, what if we provide our workers health benefits or health insurance? Is that subject to the income tax? The bureaucrats in the US Treasury were like, I don't know, Congress didn't say anything about that. Let's try to figure it out. And it turned out it was a very complex problem. So complex they threw up their hands and they said, we're not going to tax employer-sponsored health insurance, just cash, you know. This will be untaxed. And that created that penalty that I've been talking about this entire time, where if your employer gives you $1 of health insurance, no taxes, but if you take that same dollar as cash, you have to pay taxes on it, which is not an explicit penalty, but still a very real penalty on you taking that money and controlling your own health insurance decisions. That also was a point at which, you know, we no longer could have a free market in health insurance because of that huge distortion right there. And by the way, modern health insurance didn't really even emerge until 1929. That's when the first employer-sponsored plan, the first real modern employer-sponsored plan emerged in 1929, and that's when the first Kaiser-type plan emerged, was the year 1929. In fact, two of them, one in Los Angeles and one in Oklahoma, and the regulators destroyed both of them. The only reason, the medical society went after the doctors who were participating there and stripped them of their licenses. And if you don't have a license, then you can't practice medicine at all, and so they destroyed those Kaiser-type plans. You know how Henry Kaiser was able to, how Kaiser Permanente was able to succeed? Henry Kaiser was a billionaire, and he was able to use his $1 billion to build his own hospitals and break through those regulatory barriers. That's the only reason we still have one of these plans, because of extreme wealth. So that happened in 1913, again, same period. And so before those two things happened, you had free market in health insurance, or in medical care. But you know what else you had? You didn't really have modern medicine, because medical historians say that it was about 1910 that you could say, for the first time in human history, that a randomly selected patient with a randomly selected disease could walk into a randomly selected physician's office and have better than a 50-50 chance of benefiting from the encounter. That's a pretty precise, fancy way of saying, before 1910, medicine was as likely to hurt you as it was to help you. So, it was a free market, but it was not some sort of golden age of medicine being wonderful and affordable. It was really the dark ages, still the dark ages of medicine. And I would add in closing, does anyone remember the year that Chancellor Bismarck created the first universal health insurance program in Germany? Anyone remember what year?
1886, something like the 80s.
Very warm, 1883. So that is 27 years before medicine started being net beneficial. So anytime people want to tell you that universal health care or government-provided health care is compassionate and magnanimous and generous and all that, remember that the first government health care schemes were giving people greater access to something that was more likely to kill them than save their lives.
Some more questions? I see none, I guess.
Yes?
common question. How we can find the middle ground when it comes to this problem? You imply that the government regulations creates these problems, and minimum government intervention can solve these problems, I think, because it is causing it in the first place. But how we can solve this? Because you're the expert. I am actually curious about your opinion. What is the solution to this problem, other than minimum government intervention?
I think that is the solution.
Yes,
It's
and
not
what
an
else?
So on top of that, I wouldn't want to do anything, because that is what's going to unleash all of the creative energies that drive prices down by making the delivery of care more efficient and improving the quality of care and making health insurance more affordable and more secure. And so I don't want to do anything. I don't want the government to do anything that suppresses those creative energies, because that's how we make, that's the most compassionate thing that we can do, is to use those energies and those processes to bring healthcare within the reach of people who couldn't afford it. And there will still be people in a market system who don't have health insurance, who can't afford the medical care that they need, but when prices are falling, including prices for health insurance, that the number of people who can't afford the care that they need is going to get smaller and smaller and smaller all the time. And the cost of providing care to those folks, because prices are also falling, is going to get smaller and smaller still, making it easier for the rest of us to provide for them. So I don't think we need any government intervention at all. I think some people will still fall through the cracks, but any intervention you could apply would just cause those cracks to widen rather than fill them in. And I understand that not everybody shares that view, and some would still want some form of government intervention to do something for those people. If there has to be some government intervention, what I think the one that does the least amount of damage is if you just give the people you are concerned about cash. Enough cash for them to purchase the amount of medical care that you want them to purchase, or the amount of health insurance you want them to purchase, and then leave it to them to decide how to spend it. Because if you give the government the power to decide, to make those decisions instead, you end up crippling the market's ability to do the sorts of things that we've been discussing, to drive down prices, to keep prices high, to improve quality, to keep quality low, instead of improving it. Instead of making health insurance more secure, you make it less secure. And I didn't even talk about all the ways that Obamacare and the Swiss and the Dutch systems make health insurance less secure for the sick, because they really do create a race to the bottom in quality. So give them the cash. You can have redistribution from the wealthy and the healthy to the poor and the sick. You can have redistribution, but still let markets allocate the resources once you've done that redistribution. Anything further? No? Okay, thank you all very much. This has been great fun for you.